So it's my pleasure to moderate this panel discussion. The title is, as you see on the screen. And it really is a deep dive into a paper that we published in February 2023 in the Journal of Graduate Medical Education. And I would refer you to that article as notes for this lecture. You don't really have to take any notes. This is our panel, and I'll introduce them briefly now in a little bit more detail in a minute. We have Dr. Michael Gottlieb from Rush, Dr. Alex Sheng from Brown, Robert Bautista from University of Texas at Austin, and Lauren Westafar from UMass. I'm going to give you a brief introduction to the key terms and concepts that we're going to talk about today so that we're all on the same page. False information has been around as long as humans have been able to communicate with one another. But it really, as a concept, came into the public discourse in the last presidential administration, when Kellyanne Conway went on Meet the Press and coined the phrase alternative facts. And we began to hear it on Fox regularly. So misinformation is defined as false or misleading information that is distributed without malice. And when we think about COVID-19 misinformation in specific, we know that from the pandemic, misinformation led to vaccine hesitancy, so that led to lower rates of vaccinations and obviously preventable deaths. And in communities of color, misinformation is more prominent, and so were the effects of that misinformation. So vaccine hesitancy comes with complications. It prolongs the pandemic because not enough people are vaccinated. It allows for new variants to arise because not enough people are vaccinated. The pandemic will continue on. If they're not vaccinated and they somehow don't get COVID, the longer they go without COVID, the more likely they are to never get the vaccine at all. And this obviously affects mental health. So who's to blame? There's a lot of bad actors for misinformation, but social media is certainly one of them. There's one study that suggested that of the information that they analyzed in their study, 50% of it was misinformation that came from social media sites primarily. Disinformation is false or misleading information that is distributed with malice and for bad intent. And, again, the COVID-19 pandemic and the presidential election were ripe with disinformation, and, the public learned these terms very well. So this places it in infodemic. So one more term, an information epidemic. The World Health Organization has a great definition for an infodemic. They say it's too much information. It's just good information, bad information. It's just too much information. And it causes confusion in the populace, and they don't know what to do. It causes mistrust of government and public health officials, and it lengthens outbreaks. So a psychiatric term results from infodemics, and that's an information overload. Information overload causes you to have decision paralysis and stress and depression related to that. And I'll give an example. So when I go to Whole Foods to buy ketchup, I really want to just buy Heinz ketchup. But when I get there, there's like 10 organic ketchups. And I don't know which ketchup to buy because I'm not hip enough to know what organic foods I should be buying. So I leave without any ketchup at all because I had decision paralysis. So this is information overload. So the health of our nation depends on trusted information. This is out of a Surgeon General's campaign. And with that, I'll end the introduction and introduce our panelists. So Michael Gottlieb is Associate Professor and Ultrasound Division Director at Rush University Medical Center. He is a social media researcher and an editor for 7 journals, including guest associate editor for the recent Journal of Medical Internet Research special issue on social media ethics and COVID-19 misinformation. He's also the social media editor for Academic Emergency Medicine. Alex Sheng is associate professor and residency program director at Brown Emergency Medicine. He writes about how physicians can better engage patients in person on topics muddled by health misinformation. Robert Bautista is a postdoctoral fellow at the School of Information here at the University of Texas at Austin. His research includes studies examining the role and impact of correction of health misinformation on social media by health professionals. And finally, Dr. Lauren Westafar is assistant professor and research fellowship director at UMass Chan Bay State. She's a social media editor for Annals of Emergency Medicine and an implementation science researcher and podcaster. She too served as a guest editor for the Journal of Medical Internet Research special issue. All right, so with those introductions, illustrious panel, we're going to get started with some questions, and we're going to go to Mike first. So, Mike, I want you to tell us why it's important at all to be training residents about misinformation. So, to do so, I just want to hear the impact in general on society as the so what. So how does health misinformation affect patients?
Yeah, absolutely. I'm going to start off with the most important thing, which is always Heinz 57. That's always the best ketchup option
it's
without
the right one.
option.
Yep.
That's the best option. But since we're going to talk about misinformation, because that's just clear fact, is there's impact we see at society. We've seen this, right? We've gone through the COVID pandemic. We've seen the impact in terms of our patients, in terms of a lot of relatively extreme attempts that people believed in to try to, prevent, treat, or otherwise interact with COVID. Everything from bleach injections to ivermectin to avoidance of vaccines, we see this, right? And even as we kind of continue, through the course of everything that's happened with COVID, it's not that COVID was the first instance of misinformation, nor will it be the last. This has preceded it by quite a while. Think about, for example, who here in this room was told, don't go outside if it's cold, you're going to catch a cold. That was misinformation dating back before the internet, right? There has been misinformation well before that. Now some of it is more or less harmful, but this is not a novel concept, a novel construct. It's continued. But now we have the internet. Now we have ways of disseminating it further. And the problem lies in here that it can start to kind of create these issues and start to amplify them. And if we look at this from the standpoint of patients as a starting point, right? We want our patients to trust us. It's really important, especially in emergency medicine. We expect our patients, they need to be able to trust us. And when they see it as their information is correct and we have misinformation, and we see it that we are correct and they have misinformation, we're already starting at a loss. And then that trust is inhibited or potentially gone. We have to recoup that. It's not for us to say that we're going to say, okay, no, you're right, we should inject bleach. This is a good idea. But we also can't be like, that is way off base. And the more that we separate this out, it does cause harm, right? We're going to see that if people don't feel like they trust us as physicians, well, they're not going to come to us. So there's a very real impact on this, not just from the misinformation on them themselves, but how we interact with them as patients that we really need to be, cognitively aware of and actively kind of intervening upon.
So you talked about patients in that response. How about the public at large and public health? How does misinformation affect sort of the general populace that aren't patients?
Yeah, I suppose there's a couple ways that this comes into play. One of which is misinformation in general. Well, it breeds itself. It's interesting. It's catchy. Misinformation is really good for headlines, right? Turns out that bats cause cancer. Did you know that? You're going to click on that link. You're like, wow, that's really fascinating, right? Misinformation is really good at grabbing attention. And the problem is because it grabs attention, it gets forwarded and retweeted and liked and passed along. And inevitably, one of my relatives will text me this thing and be like, is this really true? I saw this, right? And I'm just afraid to open it because I don't know what is going to happen when I open this file. But we see this, right? It gets perpetuated, starts to create this. And the problem is that as it goes forward, it starts to create echo chambers. And a society that's increasingly disconnected and increasingly living with our own silos of things, misinformation breeds siloing, right? And so I think that's one of the big real risks here is that people become increasingly insulated. They continue to kind of cycle down this pathway. And then we see less contrarian viewpoints. We see less of, people kind of, stay within their small silo and then they don't get exposed to other things in the first place. I think it also can kind of just start to override trust in general. Because if I see something where it's like, turns out that drinking a glass of wine a day is really healthy for you, but also drinking a glass of wine a day will make you die sooner, I don't know what to do with that information, right? And those are both actually studies from us, let alone the breadth of things. Like when you start to see rapidly contrary views over and over again, you're like, I don't know what's true. Now for us, we'll say, like, I'm gonna read both the studies and compare them and do a journal club on it and get really nerdy and take my glasses like this and say, all right, got it. I feel like I have a good grasp of the data as of now, and I'm gonna be really conservative and say, it may. But what are patients to do with this? Well, they'll take the shorter headline because they aren't being trained in this, and that's not their fault. They weren't trained in it. They have expertise in different things. And that's not just patients, it's healthcare, it's policy experts, right? When we look at politicians who are gonna make decisions, they're not trained in a lot of this either. And so what ends up happening is we have such a broad range of information. How do we believe what to trust? I think there's a real harm to trust that exists out there, and a real harm to how we decide how to receive information and utilize it.
All right, so final question to Dr. Gottlieb. Impact of health misinformation on the system itself and the healthcare system.
So scale it up a little bit and say, let's look at us, right? If every shift we go in there, in every shift, what we say is, question is, now I've seen something differently. Now we've seen that, right? The patient, we'll talk to the patient, they'll Google this and say, well, actually, no, I saw this, I know they need an emergent MRI for my knee because I saw that that's what I need for ligament injuries. And I know that I need a CT for my head, for my child's head, because that's what's going to help me make sure that they're not going to die from a brain injury, because I saw that. And I've seen two kind of problematic outcomes come to us in kind of the healthcare system, really, when we look at it. And first one is, well, you get kind of anhedonic. You're like, oh, fine. I'm going to give you the azithromycin for your URI because I'm just tired. Like we see that, we feel that. Some days we fight the fight better, sometimes we fight the fight worse. But we've seen that, and we know that there's data showing that we over time will be more prone to give these things, within reason. I think that's one risk, right? But then the other end is that we can kind of become increasingly parentalistic. And we could say, you know what? You're wrong. Let me tell you what you need to do. And we start to bleed over and we stop listening to patients. We stop engaging in good shared decision-making of patients. Not that everything is shared decision-making, but we start to bleed over into what we did decades or centuries ago, which is the doctor is right and everyone else is wrong, and this is what you need. And I think we can get ourselves in really harmful state there too. So I think we need to kind of check ourselves a little bit and say, all right, we don't want to get anhedonic and just give in and say nothing, but we don't want to be on the other end of the spectrum saying, I know everything, you know nothing, I'm going to tell you what you need. I think we need to kind of find that middle ground, and we need to kind of challenge ourselves as misinformation will not go away, access to it, the approaches, that's not going to change. We need to be acting upon how do we address it, how do we challenge that in a way that maintains the safety, the trust, the patient-doctor relationship that we value so much.
All right, thanks for the so what. That was really great. Importance for training our residents is clear. So let's talk about how to train them, what they should be saying. So Dr. Sheng, this is to you. How do we engage patients in discussions about health misinformation?
So you guys can hear me okay? We can keep this as a conversation too, so feel free to interrupt me. There's not too many of you here. So this is difficult because I remember at the beginning of the pandemic, I had a patient who accused me of giving him COVID using the very swabs we were using to test for it. And the things I wanted to say in response is not appropriate for this venue, and it's a good thing I kept my mouth shut because, as you know, responses that belittle or dismiss people, they don't really result in any good behavioral change. They kind of push them, and it further alienates people and forces them to be further entrenched in whatever beliefs and positions they came with. And another example would be, have any of you volunteered for your hospital's vaccine promotion efforts when the COVID-19 vaccines came out? Oh, okay, so right. So I thought, look at the data, right? With the right information, people are going to make the right decisions. And during that time, there was a lot of concern over fertility, the spike protein, and a lot of people came to us with a lot of the misinformation they kind of came online. And I was probably relying too much on an information deficit model of fighting misinformation with more or better information. And that didn't turn out as well as I probably had hoped. Because people didn't really necessarily trust the source of the information just yet. So basically being too parentalistic, too prescriptive in person, they kind of ignore the underlying sociocultural, emotional, now political factors that drive people towards misinformation in the first place, and they ignore that crucial component building trust. What I try to do is just, because trust legitimizes anything I say, I use a combination of techniques of what I knew from before and what I've learned through this process and what's the kind of the latest and the best recommendations out there. And unfortunately, there are some good approaches based on social behavioral sciences that we can use. Motivational interviewing techniques are really good. We already use that approach for patients with substance use disorders, and it's actually been shown to improve childhood vaccinations when using that approach as well. And that's an area that's super ripe with misinformation well before the pandemic ever happened. Conversational receptiveness is a really cool concept that I was doing some research with the people that came up with it on. It's a set of phrases, or what they call linguistic markers, you can put into your daily conversation with maybe your boss, maybe your partner, as you're negotiating and talking about, maybe conflicting issues or divisive issues. And when you add these terms into your language, it makes you seem more intelligent, objective, and more trustworthy. So an example would be finding points of agreement, or hedging on your claims a little bit and giving a little bit of ground during your conversation, but then also kind of saying, if you're weighing the benefits and risks, it still turns out the vaccination approach is better. Yes, COVID-19 vaccine doesn't prevent COVID, but, and it's important to kind of bridge that gap a little bit, staying positive. It's an approach that's mimicked as well. So if I'm super collaborative, emotionally, engaging with you, it's hard for y'all just to blow me off during that conversation. And actually, it can be taught fairly easily as well. They've trained thousands and thousands of lay public just through texting to improve a lot of engagement during. Their primary research was in political issues, and it did show a lot of improvement there as well. Another thing something I've used for a long time as an educator is kind of the learner-centered approaches we use every day for our trainees. Establishing a good learning environment, safe learning environment, building that educational alliance, scaffolding building upon their prior knowledge. I feel like all these same concepts work just as well for a medical trainee as probably someone who's vaccine hesitant or have misconceptions about different health issues as well.
Well, you answered my second question already, so that was good. That was efficient. Are there special techniques that are easy to remember? So what can the audience go home with a little kernel of knowledge?
Yeah, so we have a QR code at the end that links to the conversational receptiveness concepts, motivational interviewing. But those techniques do require some training. Motivational interviewing is like a many hours workshop, a lot of practice. Conversational receptiveness is very easily taught overall, but still takes some time. But in our QR code, you'll see at the end, there's some practical resources you can just build into your discussion and for your next shift. So MisinfoRx has a nice 3 C's approach based on compassionate understanding, connection, and collaboration. The COVID-19 vaccine handbook has a lot of good recommendations based on what's called an elicit, share, elicit approach. So an example would be, I see you came to us with some concerns about the COVID-19 vaccine and the side effects and the potential impact on fertility. Is it okay if I share with you my understanding of the literature based on what I've reviewed? You get permission. After you elicit that permission, then you share what your understanding is. You start with the fact that it does not, like COVID-19 vaccine does not impact fertility. You can go over that the spike protein is very different. You can go over the fact that many people became pregnant during the studies, did well, and people who were pregnant as well in some future studies. And then you end with another illicit question of just saying, now that we've reviewed, kind of what we discussed today, like what are your thoughts about this? And if there, or what other questions do you have? And opens the door for further conversations, even if they're not ready to proceed right away. And then I think one of the best resources in our QR code is called the Debunking Handbook. It's a consensus document from a multidisciplinary group of scientists who do crazy amounts of high-level research on fighting misinformation. They really distill some of the latest research findings and give some practical recommendations as well. And all those will be in our QR code.
All right, finally, pitfalls. So we can screw this up, these conversations. So what pitfalls are there?
Yeah, so similar, kind of what I've answered before in terms of being too parental-istic, being too prescriptive, being too information-focused, and belittling or dismissing people. All those things just unfortunately don't work as much as it can be tempting to. I had an example where I had a super sick septic gallbladder patient I just remember the exact room of the ER at that moment, and in order to be admitted to the hospital, you have to get a COVID swab, and they just outright, both the patient and her husband, refused to do it. Don't believe in COVID, does not exist, we would rather leave. Both me and the surgeon were in and out of the room, like, you're really sick, you need to get this taken care of. And for every expert or every resource I can tell them about, they have a whole set of different experts and resources they can draw upon to kind of, so it was really difficult to bridge that gap, but in the end, she ended up getting sicker and they had no choice but to get the swab and get admitted. So it was difficult. So I think at that time, I wasn't quite as probably ready to have these conversations based on some of the techniques I've learned over the last couple of years, but hopefully I'll do better next time.
What you're talking about is fixed mindset, right? So, there's a continuum of vaccine acceptance, vaccine hesitancy, and then fixed mindset being the folks who are totally anti-vax. And, they have characteristics about their cohort, right? They're narcissists, they're anti-science, they're anti-society, and very individualistic. And you can't change that. You can't change a fixed belief in a 15-minute encounter. It's just not possible. So you have to focus on the vaccine hesitant people, not the folks who are anti-vax. All right, Dr. Bautista, why should we correct health misinformation on social media?
Yeah, so much of my research for the past 3 years was about correcting health misinformation on social media with emphasis on what healthcare professionals can do. Primarily doctors and nurses. So one lesson I learned is that in terms of the word correction, some people would refer to it as correction on the social sciences, like social correction, where other people correct other people. The other term might be debunking, which is, they're fairly similar. The word debunking is much more popular in the UK. For the US, it's usually correction. But in the context of social media, the difference in terms of the context is that you're dealing with random people and not patients. And when you're dealing with random people, there's always this risk for harassment. I've heard so many horror stories about health professionals getting harassed on social media simply because that they actually given correction. But what are some of the things that I recommend in correcting health misinformation on social media? There are 2 ways that you can correct, but one of those is I'll recommend. The first one is you can do a priming. A priming means that you can post the correct information on your social media and have others to share it. Rebuttal is another form, which is you saw a misinformation posted on, let's say, Twitter, where most folks are present. You can actually post the correction as a reply into that misinformation. The problem with rebuttal is that you open up yourself to harassment sometimes. And based on Twitter, like how it displays replies, typically the reply is not like when you reply your correction, it's not that easily seen based on heuristics. It's like you have the misinformation, then you have your reply is like just below the misinformation, which is not really that visually appealing for people to actually see. So between a priming and rebuttal, what I recommend is for health professionals, whether it's Facebook, which is getting old for most people, Twitter, people are still on Twitter, people are migrating now to Mastodon. The new frontier is TikTok. Okay, the new frontier is TikTok. It's useless to do a reply on TikTok. What you can do is like you actually share the information on your own page. Like you post it on your Twitter, you can create your own video on TikTok. And you don't need to like point fingers on someone that this person is providing misinformation about this topic because you don't want to reinforce the misinformation. I mean, good publicity, bad publicity, still publicity. There was a time for WHO in March that when they were creating like correction cards in terms of some of the misinformation about COVID, they actually had the misinformation on top. Then like misinformation, then what is the fact? What's the correction? They actually changed it around April, May, simply because that people remember the misinformation than the correction. So you start with correction, then they have this small sentence about that misinformation that doesn't really get emphasized. Then they end with another fact to reinforce the first statement that they did. So that is somewhat, I would say, applicable on social media. And I think my general advice is don't reply to misinformation posts. You rather just post on your own. Or if you don't have time to post on your own, you can actually just find someone's post, like for example, Peter Hotes, who just posts lots of stuff that corrects details about vaccine misinformation. So he provides correction. You can just simply share that. So if you don't have time to curate your own post, which really takes time, you can actually share other people's correction and have it, hopefully people who need it the most would actually be able to read it. So instead of doing rebuttals, I would suggest doing priming.
Is there a particular dance you would recommend for healthcare providers?
Okay, one thing that people really like is that you don't really need to dance a lot. It's like sometimes like, you actually point on invisible boxes, then you put in text on those boxes. The text would provide the corrections. So you don't really need to like full-blown dance. It's like you just giggle yourself, like point here, point here, point here, point here, point here, point here, then some background music, catchy ones that Gen Z people would relate to, I think. So I think most of my research are still situated on Twitter because like back in 2019, 2020, Twitter is still full-blown with misinformation, but now we're on the new frontier, which is TikTok.
I think Dr. Pimple Popper is a really good example of that, right?
Yeah.
So she only uses correct information. She doesn't rebut misinformation. All right, so how crucial is support from healthcare institutions?
Yes, health institutions have a love and hate relationship on social media. There was a time like early 2010s wherein it's like they actually warned health professionals not to be on social media. It's really a love-hate relationship. As much as they want to be present on social media, they're actually giving harsh advice or harsh policies to their staff to be really careful on social media, to the point that it impedes health professionals' somewhat motivation to engage the public using that platform. At least on my own research, what I found is that so I did a survey with nurses and doctors, and I asked them, it's like, to what extent does people in your organization support when you correct health misinformation on social media? So I asked like support from coworkers, support from hospital administration, support from patients, support from fellow health workers. And what I found is that if that health professional thinks that they're being supported, they're more likely to have a much better attitude on doing the correction, and they're more likely to have a greater intention to correct health misinformation. So it really starts with institutional support. And that is something that is known right now because the US Surgeon General explicits on that guideline that they released in 2021 that health institutions and health professionals need to work together to address health misinformation, whether it's on social media or in in-person clinical encounters. So I think that's how important is support from health institutions. It actually motivates your health professionals to better engage the public on social media without thinking much of the negative repercussions that would happen.
All right, so final question. How can healthcare institutions support our efforts online, so specifically us?
So I think that's very important. So how do we make this concrete? One way is for health institutions to think of addressing health misinformation and engage and working with their health professionals as part of their corporate social responsibility to the public. I think that starts there. So it's like they actually need to review social media policies, like their existing social media policies. Are there stuff within those social that on their social media policy that would prevent someone in engaging the public? I'm not familiar with specific wordings within social media policies, but at least from the there have been recent news in terms of like physicians, at least in California, will be penalized if they spread misinformation, and that kind of statement in hospital policies might be undergoing as of now. And I think one way that they would be able to support such a mission in addressing health misinformation is provide funding for trainings. Then, I mean, if a certain department, like the departments of our colleagues here at the different medical departments, hopefully the institution provides funding for misinformation training, not only for doctors, but to other health professionals that are within that hospital. So I think that's because I think the top three professions that encounter health misinformation are: one is doctors, physicians; second are nurses; third are pharmacists, simply because of the drugs. So at least those three would need a lot of training, and there needs to be support from health institutions for that. Another type of support that they could give is really checking the policy. Like, are we making sure that our policy is conducive for our health professionals to engage the public on social media? So I think those are some of the things that I think of in terms of organizational support.
All right, thanks. I'm very grateful for you coming to an emergency medicine conference and sharing your expertise from your work. So we're very grateful. That was wonderful.
Yeah, thank you.
And our last panelist, last but not least, is Dr. Westafar. So we're going to have some fun and talk about celebrities. What are their impact on misinformation?
Yeah, celebrities, I think we know who many are when you've seen misinformation on the news, maybe former presidents. They only account for 20% of those that are contributing misinformation, generating it out there. But as you can imagine, their impact is pretty profound. Almost 70% of engagement around misinformation comes from that 20%, which makes sense. They're celebrities and politicians because they're really good at spreading information. And so that's sort of top-down misinformation. They're at the top, they're these leaders, and they're spreading information down to lay people who are eating it up. But misinformation spread also comes from the general public and people who aren't, because right now, anybody can be an influencer, right? Med students boast on TikTok about making $60,000 as med students talking about how to make money on TikTok being an influencer, and that's literally their platform. So anyone can really be an expert, and I think that's where you see some of this role of training like you were talking about, because they're also the other 80% of those that are generating the misinformation are people that are just run-of-the-mill type people, or not quite celebrity politician status, but can sort of generate that misinformation. For example, right now there's a third-year med student who is perpetuating some of the old COVID misinformation sort of repeatedly and leaning on the fact that he's a PhD. And again, it's going viral, generating a lot of engagement, even though he beforehand was not a celebrity. He was theoretically just a med student.
Okay. Are there other important sources, you perhaps touched on this already, but other sources of misinformation that you think are important for our discussion today?
Yeah, I mean, I think anything and anyone can generate misinformation, and sometimes initially it's not perceived as misinformation, and so I think that it can come from anywhere at any time, and doesn't necessarily have to be pictured in this like infographic by a celebrity, and it can start much slower, much sort of low key, and then build into that.
All right, and our final question, how do we respond? So how should we craft our messages, specifically online?
Depends on how feisty you're feeling. I think when we talk about crafting messages, it's always, think about what is your goal and what is your audience. Because if your goal is, that makes me really mad and I need to tell them, my recommendation to craft your message is to craft it and then save it as a draft and then go back and delete it. Like, that's what I do. I have that angry moment and then I just let it go because I need to tell them, but they don't actually need to hear it because they're not gonna hear it anyways. So what is the goal? Is it a rebuttal? Is it a correction? Do you want to put stuff out there to inoculate people, to help them identify misinformation? So once you've solidified your goal, you can think about how do you craft it, and you also need to think about your audience. Are you targeting fellow physicians? Are you targeting trainees? Are you targeting lay people? Because that will help you identify how technical you need to be, and then what are you gonna put in there? Because ideally, when you're doing this, especially around misinformation, one model that's been proposed is sort of, to correct misinformation, is fact, warn, fallacy, fact. So you start with a fact and you leave them with a fact so that that's what they remember. And then you explain the fallacy. So fact, the vaccine, COVID-19 vaccine is safe for pregnant people, right? Fact, we know that. And you warn them, you say, hey, I'm gonna share some information with you about what people have said. You might have heard some misinformation about the COVID-19 vaccine and pregnancy. I'm going to tell you, it's there's this misconception coming, and then you explain the fallacy and you explain why. So you might have heard that the COVID-19 vaccine contains a protein sequence that is very similar to this placental protein, and that's where this misinformation comes from. And you know what? It does. 4 of the amino acid sequences are similar out of 598. So less than 1%. And what happens is when people don't understand that anything can be similar, we all have these proteins that are similar, that's where that fallacy came from. It was rooted in something real and misconstrued. And then you end with the fact again. But you can also do pre-bunking, which is super fun. So they've even created video games and apps where they basically inoculate and train people to identify misinformation. So it's the idea that you're training people how people are generating content to create likes. Because that's what all the generations are doing now, is how do I get more likes? How do I get more retweets? Or what's on TikTok? I don't know. But how do I get more engagement? And oftentimes that's generated by financial compensation. And so thinking about how do you make it catchy? You always add a graphic or something, but you can actually train people to spot the misinformation in those graphics and stuff as well. That's called pre-bunking instead of debunking, because you're doing it beforehand, which is just another way. And then there's the simple stuff with the message. Use a graphic and use credible sources that are specific to your audience, right? I'm not gonna post a PubMed link if I'm targeting lay people, right? Because even our residents, even many physicians cannot understand papers on PubMed and just link another paper that supports what, for me, I'm only gonna cite the red wine studies that support health, and not the ones, so there's a lot of selectiveness in there. So choosing what source you wanna be and then figuring out what games they're playing and how do you make that catchy as well.
All right, so that ends our panelist questions, but I wanted to throw a couple spontaneous questions at the panel, and then solicit audience questions if you have questions or comments on what we talked about. So anyone on the panel can answer this question, just one of you, though, and we'll keep the response brief. The first question is, what is the current state of EM training about health misinformation?
So, not much, unfortunately. There's a lot of different communication models that are in undergraduate medical education and in graduate medical education that covers the clinical stuff. Having difficult conversations, having working with teams, maybe talking with consultants, end of life discussions. There's really nothing that's been either rigorously developed or studied at the undergraduate or graduate medical education level as it relates to combating health misinformation.
And final question, what is the role of graduate medical education in these efforts?
Guess I'll tackle that one. So if there's a giant gaping hole of this, then we need to address it, right? We realize misinformation is a clear issue. All of us face this. Like even if you're outside the medical field, you face this, and we definitely face it in the medical field. So we're gonna face this, and we don't have a plan. Step one, find a plan. I think it's incumbent upon us to start building this into training. Some of it is studying and figuring out what's the best modality for teaching, the same way we do with anything else. We need to develop curricula, figure out, do some program evaluations, figure out what's the better models, and how do we integrate this into an ever-packed curricular time. But it's important enough we have to find a way to do so. We just have to find what's the best way. And even outside of building the curriculum, I think we, with our learners, have an opportunity to model this, right? We can coach them through it. If they're saying, hey, I have a patient who's telling me that they will refuse to vaccinate their kid, but I think they might actually be on the susceptible area for change. What do I do? Right? We can show them, we can coach them through it, we can model it, we can kind of work with them to help make sure they develop that skill set, even as the same way that we do when someone comes in with hyperkalemia. We're not like, oh, they have hyperkalemia? Well, I don't know what they're gonna do. I guess we'll have to let them go home. Like, we're gonna treat it, right? And we're gonna teach our learners how to treat it so they can do it on their own. So when they leave, they're able to have that skill set. And I think it's incumbent upon us to do the same thing we do for clinical care as we do for misinformation care. And so I think we have things we can do now, and then we have areas that we need to work on as a field too.
Yeah, that faculty role modeling and coaching is really important. And unfortunately, most faculty are not as adept as social media and having these conversations that Dr. Gottlieb is. So there's really, we need to start with training the faculty as well. And that's a huge area of deficiency. And I think the last thing was what Rob already mentioned, is institutional sponsorship for physicians who want to engage and debunk online. And maybe at some point, as this changes, hopefully changes over the next decade, we don't have to say, my own opinion only on every single Twitter feed that we have out there. So.
All right, well, let's turn to our audience. If you'd like to make a comment or ask a question, or perhaps tell us why you came to this lecture on Friday of SAEM in the last slot.
Select group.
I would like to know that too.
And I just started my third year, and I was seeing a patient in an outpatient office with my preceptor, and this was like a welfare patient. They followed several physicians, and they started talking kind of about toxins in their body, and became clear on reviewing their med list. They were very into supplements and alternative medicine, and we've been trained in our doctoring course just on how to intervene with misinformation a little bit. I think I remember the illicit, informed, illicit approach was emphasized for vaccine counseling. But it quickly became clear this patient had an entire different system of education, which might have been supported with some of the other doctors they were seeing. And I felt very ignorant of all the knowledge that the misinformation that they were knowledgeable in. And I wanted to ask as providers, how much work do you educate yourself on what patients might be coming in with in terms of misinformation, especially when it comes to things that have a lot of money behind them, like the supplement business. How do you balance that with all the other things
That's a great question because you know, I had a friend of mine who can pull up any animal-related study that would, you know, really, you know, make whatever treatments I'm saying was good look terrible. But you know, they don't understand kind of the levels of quality of evidence that, you know, we kind of have to go over. So I do have to spend some time looking at the exact literature that, you know, they send me, and that takes a significant amount of time. But I think there is some opportunity to both like legitimize this concern within the animal studies, but also, you know, teaching them a little bit about how, you know, in more, you know, robust trials, then where there's no harm or something like that. So that was kind of an example I could think of, but it does take some time to dig into that a little bit.
Do you have any comments, questions?
Sure.
There you go. All right.
So it's Mass Bay State, partially for sport, but also I think it's you know, it's a really interesting and important concept that I've struggled with my own personal journey through social media. As probably Dr. Westafar has seen, like I was on for a bit and amassed a huge following of about 200 to 250 people on Twitter. But then it really, like personally, it sucked in, and it took a lot of that personal effort to fight and to like review and to try to do good things to do. And I also felt not only the echo chamber of people that didn't believe me, but then the echo chamber of people that I was just posting to people that had the same thoughts, right? Like my echo chamber of harm reduction, substance use disorder, like I'm hearing the same things. And it really like interrupted, like it was time not spent with family, it was time not being compensated. And so especially for the past few years, I've just turned it on and done the other way, taken it up. And I wonder for you all, like, how do you balance, right? Like, because you all, I don't know some of you, but I imagine like all of you are incredibly busy in many parts of life. And how do you find that balance of kind of serving that role to combat while also not letting it kind of overtake what you do?
So I don't actively combat as much in terms of like trying to form a rebuttal or something. I use it as mostly as information gathering. So I use it like, what are people saying? And for me, my biggest, you know, dearest thing with regards to misinformation is the disutility of the D-dimer. It's not even related to COVID. It's the bad rap of that. And so I use it to see, like, because I need to know what are other people saying, because if I only engage with the people at Bay State, and if I only engage in my own academic emergency medicine, I'm not going to know what other community clinicians, and so for the same reason why I like moonlight at other places so I can still practice emergency medicine without residents, I still need to know that. And so it's my information gathering. And then I select what is important to me as what I'm going to actively go out there correct. And how I do it is not necessarily replies on social media. I find something that gets my gears and I write about it in ASAP Now because that's what people actually read. I put it on my podcast because that's what I like doing. And then I put it on Twitter where it may or may not have anybody that actually reads it. And then I lecture about it to our residents and then they make our attendings change their practice. So I do it about things that are important to me because I don't spend a lot of time on social media for somebody who built their career on social media.
All right, well, with that, we're close to time, so thank you for coming to the last lecture and the last day, your troopers, and thanks to our expert panel. You guys did a great job.